Up next, we have a special guest presenter from the City of Hope Medical Center located in California, and that is Dr. Raoof. Dr. Raoof is a surgical oncologist and assistant clinical professor, as I said, at the City of Hope Cancer Center. He focuses on the surgical treatment of cancers within the abdominal cavity, particularly those from the liver, bile duct, pancreas, and gastrointestinal tract. Dr. Raoof conducts laboratory research focusing on DNA repair mechanisms in cancers, and his mission is to deliver complex surgical oncology care with expertise and compassion, as well as to develop new therapies for patients with GI cancers. Thank you so much, Dr. Raoof, for joining us today, and we look forward to your presentation.
Thank you for inviting me today to speak at the Appendix Cancer Survivorship Symposium. I will be giving an overview of the PIPAC and the management of appendiceal cancers. So in the next 10 minutes, my goal is to introduce the concept of PIPAC and rationale for its use in appendiceal cancers. I would like to discuss PIPAC procedure, and then I would also like to give an overview of the US PIPAC trials and eligibility. So the rationale for PIPAC and appendiceal cancers, everyone knows here appendix cancer is rare, about 1,500 cases per year in the US, 32% of patients will present with appendicitis. And at the time of diagnosis, half of the patients will already have metastases to the peritoneum, and many others will have other distant metastases. Appendix cancer is a spectrum, starts from normal duct to hyperplasia to dysplasia to invasive carcinoma, and all of these have been there have been names associated with each category, and this is one condition where even non-invasive type of cancer can be life-threatening. We all know that high-grade disease has the worst survival, and low and moderate-grade disease tend to do better. For low-grade neoplasms or low-grade adenocarcinomas, cytoreductive surgery and heated intraperitoneal chemotherapy has become the standard of care. And when patients are managed this way, we can ensure excellent long-term survival for these patients. For high-grade disease, on the other hand, this remains a significant challenge. We typically see early recurrences in patients who are treated with cytoreductive surgery and HIPEC, and most centers at this time will introduce some form of chemotherapy before selecting patients and taking them for a major operation. Most patients will also require postoperative chemotherapy. When patients are managed in this way, this is very typical of the survival curves that we see. Patients who've had a complete cytoreduction, HIPEC, perioperative chemotherapy, their median survival can be as high as 4.2 months. This series from MD Anderson Cancer Center. Patients who never go on to complete cytoreduction or have just treated with systemic therapy or incomplete cytoreduction have a median survival of about 1.7 years. So these are the challenges that we see. So we need therapy, a therapy that can downstage patients, meaning more patients can be candidates for cytoreductive surgery. We also need a strategy to better select patients who will be well suited for any form of cytoreductive surgery. In chemorefractory setting, where patients are not resectable and they've been treated with 1 or 2 lines of chemotherapy, better therapies are needed, and we need an intervention that could improve survival in that setting as well as quality of life. And then in the post-resection setting, a therapy that can potentially prevent recurrences can potentially also improve survival, and therapies are needed in that space as well. So PIPAC is a novel approach to treat patients with peritoneal metastases. This is a laparoscopic procedure where abdominal cavity access is established as shown using trocars, and then chemotherapy is introduced as if to fumigate the abdomen with chemotherapy. And so looking back at the data that has led to the development of PIPAC, this is a swine study where in the swine model, aerosolized methylene blue was given, and you can see all surfaces were stained with methylene blue. when these animals were compared to those that had the PIPAC T1 and T2 compared to the control model, which was treated with methylene blue lavage. We could see more deposition of methylene blue in the PIPAC arm. And more recently, there's been a study comparing HIPEC and PIPAC in terms of distribution of the chemotherapy. These investigators divided the abdominal cavity into 10 sections, and the HIPEC was given at a dose that is used clinically, 75 milligram per meter square for 60 minutes, and PIPAC was given at 7.5 milligram per meter square. As you can see, HIPEC results in more platinum distributed, but when you look at the dose that was used, given that the dose in PIPAC was tenfold lower, the yield of tumor deposition is much higher with PIPAC, and the systemic concentration as a result is much less compared to what is achieved with HIPEC. So we want less drug in the systemic circulation to minimize toxic effects. So PIPAC has now been used in several studies worldwide. This is a report as of 2019, and several thousand additional procedures have since been done. But in this report, they summarize the findings from the first 1,800 procedures in 838 patients across 45 clinical studies. In this summary of heterogeneous patients, what we find that 64% of patients will undergo at least 2 PIPACs. The adverse event rates were low, 12 to 15%, which is much lower than systemic chemotherapies, which are on the average of about 30% or higher. And the objective response rates measured through several criteria, several different criteria, ranged from 60 to 70 to 80%. Across different disease types. Now, the way we measure response is up to debate, and so it's not clear as to what that response means in terms of the traditional measures of measuring response, like RECIST criteria that we use radiographically. So this is a landscape of the ongoing PIPAC clinical trials through the clinicaltrials.gov website. And we see that there are many trials in different GI malignancies as well as gynecologic malignancies, majority of them investigating the 2 regimens, which is either cisplatin plus doxorubicin, and the other regimen is oxaliplatin. Some of these studies, like the PIPAC STOK01 from France, is a randomized trial comparing systemic therapy versus systemic therapy plus PIPAC in first-line setting for gastric cancer. And similarly, Mesotip is also a randomized trial from France. So the advantages are, this is a minimally invasive technique. It's repeated every 6 weeks or so. It's ambulatory surgery. Patients typically will leave the hospital the next day or the day after. High dose of therapy delivered directly to the most threatening tumors, especially those involving the small intestine, which can cause obstruction. There appears to be high tumor penetration due to pressure in preclinical models, and the studies thus far on quality of life, although limited, have shown that the quality of life is preserved through the course of PIPAC treatments. So let me go over the PIPAC operative setup. I've shown this picture before. On the screen right, you will see the injector, and the tubing connects from the injector to the capnopen, or the aerosolizing device, which is placed in one of the trocars, as you can see over here. And usually before the trocar is placed, we establish abdominal cavity access. And we do this using the techniques published by Glatz. Basically, a 3 centimeter midline laparotomy is first created in the center using the Hassan technique. It's a more generous Hassan incision, and then the rest of the ports are subsequently placed under vision. This is necessary because carcinomatosis usually will cause a lot of adhesions to the anterior abdominal wall. And if there's a serosal injury or an enterotomy created at the time of the PIPAC procedure, usually we will need to delay or abort the PIPAC procedure because the risk of enteric leak in that setting is significantly high and prohibitive. After the axis is established, we proceed with the survey of the abdomen. We calculate the carcinomatosis burden. We evacuate the ascites and collect it for research studies. Then we proceed with performing 4-quadrant biopsies of tumor as well as normal samples. We use balloon trocars to create an adequate seal so the aerosol chemotherapy does not leak into the operating room. There's 3 levels of safety that we ensure, which I will not be able to cover in this talk. Once the samples are collected, everybody leaves the operating room, and you can see our anesthesiologist across on the other side from the door. And you can see the PIPAC injector with 2 types of chemotherapies loaded. In this case, it's cisplatin and doxorubicin. And the tubing comes on over the drapes to the patient, and the capnopen is injected in one of the trocars. The monitors are facing the substerile room where the anesthesiologist can remotely monitor the patient. And you can't see the IV access, but the anesthesiologist has the IV access remotely, and the injector is activated remotely as well. So this is the screen, how it looks like when the injector is activated. And this is the loading of the chemotherapy agents on the injector. This is a conventional injector that we use for CT contrast injection during CAT scan images. So the aerosolizer can aerosolize a wide range of materials, including nanotherapeutics, oncolytic viruses, and such. And it has many research uses at this point. Once everybody leaves the room, we are then able to press a button remotely and activate the aerosolization. It takes about 5 to 6 minutes to aerosolize the chemotherapy, and we let it precipitate for 30 minutes. And then the pneumoperitoneum is evacuated, at which point we take post-PIPAC biopsies and the procedure is completed. So the first US clinical trial was 2-arm trial. Arm 1 included ovarian, uterine, and gastric cancer patients, as well as soft tissue sarcoma or DSRCT patients. And Arm 2 included colorectal and appendiceal cancer patients. As you can see, the arms are decided based off of the chemotherapies we're using. In case of colorectal and appendiceal, the first PIPAC only had oxaliplatin, 90 milligram per meter square, whereas in PIPAC 2 and PIPAC 3, we were using a sensitizing dose of 5-FU leucovorin at 400 milligram per meter square. This is borrowed from the French studies demonstrating sensitization of intraperitoneal oxaliplatin when given with low-dose 5-FU and leucovorin. The primary objective of this trial is to establish the safety. We are not dose escalating. We are essentially establishing the safety in the US setting. This trial is also allowing us to develop a collaborative approach to doing PIPAC and laying the foundation for future trials as well. So in this trial, we're using 90 milligram per meter square of oxaliplatin. We measure dose limiting toxicities for up to about 6 weeks, and adverse events are monitored for 18 weeks. And then during these time points, we are collecting tissue as well as blood for translational studies. So to date, so this trial is in collaboration with Northwell, Mayo Clinic, and NCI. We have accrued 6 out of 11 patients in Arm 1 and 9 out of 11 patients in Arm 2. So this is exciting because for the first time, we are able to longitudinally evaluate patients' tumor and look at changes in subclonal evolution, genomic heterogeneity, as well as the tumor microenvironment. We are conducting pharmacokinetic studies and tumor penetration of the chemotherapy, and we are also evaluating some novel circulating biomarkers to see if we can improve on the current yield and sensitivity of circulating tumor DNA and other types of analysis that are available. So going forward, so the trial I just presented before was in the chemo-refractory setting. Patients should have had progression on 1 or 2nd line chemotherapy. Most patients in the trial that were accrued have had progression on 2 lines of chemotherapy. The next trial is moving PIPAC up in terms of therapy. We are including patients who are not yet chemorefractory. They should have been treated with at least 4 months of first or second line chemotherapy, and they're not candidates for cytoreductive surgery. This is a dose escalation trial. The choice of chemotherapy here is mitomycin C. There are other phase 2 trials happening in this space with oxaliplatin. So this trial is different from the other trials. For the first time, we will be formally investigating mitomycin C in the PIPAC setting. Mitomycin C is the drug we most commonly use in the US for treatment of appendiceal cancer with cytoreductive surgery and HIPEC. And so in this study, we have 4 dose levels, and patients who are treated with at least 4 months of chemotherapy will be allowed to be enrolled. We exclude patients who have distant disease or who have bowel obstruction. Prior chemotherapy should be per standard of care. And the interesting or novel aspect of this trial is that we will be combining FOLFIRI systemic chemotherapy with mitomycin C. And we will be testing the feasibility as well as safety of doing a combined approach in this fashion. And again, we will be collecting tumor samples as well as blood through the course of the study to evaluate biomarkers and other translational objectives. So this is the City of Hope PIPAC peritoneal surface malignancy team. I'm very grateful to be funded through several organizations, both for appendiceal cancer work as well as my pancreatic cancer research program. I am happy to engage with anybody who has any questions about our ongoing studies. Thank you very much.